Did you know that a seemingly minor infection can quietly ascend and create long-term consequences for fertility? This condition is called pelvic inflammatory disease, or PID. PID is an infection and inflammation of the upper female reproductive organs. It affects organs higher up than the vagina or external genitals. Understanding this distinction is critical. The key internal structures are the uterus, fallopian tubes, and ovaries. The uterus is the muscular organ where a fetus develops. Fallopian tubes are the delicate pathways connecting ovaries to the uterus. The ovaries produce eggs and hormones. PID happens when bacteria travel past the cervix into these upper organs. The body's inflammatory response fights infection but can damage delicate tissue. That healing can cause scar tissue and adhesions. Think of the reproductive tract as one continuous pathway. Infections can travel upward along it. It begins at the external vulva, through the vagina, and up to the cervix. The cervix is the gateway to the uterus. From the uterus, fallopian tubes extend like two arms toward the ovaries. Infection reaching the tubes, salpingitis, is especially problematic. This upward migration is what defines PID. The journey of an infection from the lower tract to the upper organs requires a breach in defenses. It typically begins in the vagina or the cervix. Harmful bacteria, often STIs, can colonize the cervix and cause cervicitis. From there, microbes can enter the normally sterile uterus. Endometritis. One key gatekeeper is cervical mucus. It plugs the cervix and traps bacteria. But the mucus thins during ovulation to let sperm through, which also lowers bacterial resistance. Some bacteria produce enzymes that degrade mucus, allowing ascent. Once past the cervix, bacteria can invade the fallopian tubes. Infection of the tubes is called salpingitis. If ovaries are involved, salpingo-oophorytis. The body sends neutrophils and lymphocytes to fight the infection. Inflammation damages tubal epithelium and the tubes can fill with pus. Healing lays down scar tissue, creating adhesions and dead-end pouches. Pus can form tubo-ovarian abscesses. Pockets of fluid are hydrosalpinx, both serious complications. Inflammation can even spread to the peritoneum and liver capsule, Fitzhugh-Curtis syndrome. This cascade is what makes PID dangerous for future fertility and health. In short, lower tract infection, breach, ascent, inflammation, scarring. Preventing ascent is therefore essential. Next, the specific organisms and risk factors that most commonly cause PID. When we look at causes, two bacteria come up most often. Neisseria gonorrhoeae, the cause of gonorrhea. Chlamydia trachomatis, the cause of chlamydia. Many PID cases follow untreated gonorrhea or chlamydia that ascend from the cervix. Sexually active individuals, especially under 25, are at higher risk. Multiple or new sexual partners increase risk. Consistent condom use and STI screening reduce that risk. PID is often polymicrobial. Multiple bacteria can be involved. An initial STI can disrupt the vaginal microbiome, enabling opportunists to overgrow. Bacterial vaginosis is a common non-STI related factor in some PID cases. Certain procedures can also introduce bacteria into the uterus. Instrumentation like IUD insertion, abortion, or childbirth can temporarily disrupt barriers. With proper sterile technique, the risk is low, but the route exists. Because causes vary, treatment often needs broad coverage. Testing for chlamydia and gonorrhea remains essential. Next, how PID presents and why diagnosis can be tricky. Primary culprits, gonorrhea and chlamydia. Risk factors, age, partners, microbiome disruption. Prevention via condoms and screening can stop PID before it starts. PID's presentation varies. Sudden severe pain, subtle discomfort, or none at all. Some experience unmistakable symptoms, others remain largely asymptomatic. That silent progression is dangerous because damage can occur without obvious signs. Common symptoms center around pelvic pain, dull or severe. Pain may worsen with intercourse or pelvic exams. Other signs: abnormal vaginal discharge, irregular bleeding, fever. Diagnosing PID is a clinical puzzle. There is no single definitive test. Providers rely on history and pelvic exam findings. Key finding: cervical motion tenderness on bimanual exam. Swabs with nucleic acid amplification test can detect chlamydia and gonorrhea. Blood tests may show infection or inflammation. Ultrasound can reveal fluid-filled tubes, hydrosalpinx or tubo-ovarian abscess. In rare or complex cases, laparoscopy directly visualizes pelvic organs. Often, clinical suspicion drives treatment even without perfect test confirmation. High index of suspicion is crucial. Do not wait for dramatic signs. Ask about sexual history, discharge, and new partners. A timely pelvic exam and appropriate testing can prevent long-term damage. Because symptoms vary, patients should seek care for pelvic pain or abnormal discharge. If imaging suggests abscesses, act quickly. Management differs. Next, treatment principles. Why early broad antibiotics matter. Early recognition and testing help prevent irreversible scarring. Coming up, treatment and long-term effects. The cornerstone of PID treatment is prompt, aggressive antibiotic therapy. Because PID is bacterial, the goal is to eradicate pathogens before scarring. Treatment is typically broad-spectrum to cover likely organisms. This is because PID can be polymicrobial and you may not know every species involved. Typical initial therapy often includes an injection like ceftriaxone, followed by 14 days of oral doxycycline, often with metronidazole. Completing the full course is critical even if symptoms improve early. Pain relief with acetaminophen or ibuprofen helps while antibiotics work. Notify and treat recent sexual partners to prevent reinfection. Abstain from sex until treatment is complete and a clinician clears you. Hospitalization is needed if the person is very ill, pregnant, or can't tolerate oral meds. Intravenous antibiotics provide higher drug levels in severe cases. Non-resolving or ruptured tubo-ovarian abscesses may require surgical drainage. Most PID can be treated outpatient. Follow-up ensures resolution. Return if symptoms persist, stopping early risks, relapse, and complications. Chronic pain may need multidisciplinary management over time. Support and clear instructions help recovery at home. Communicate with partners. Community health reduces spread. Even with treatment, prior PID episodes can carry long-term risks. Next, we examine those consequences. The true tragedy of PID is often the permanent consequences after the infection clears. Inflammation triggers scar tissue and adhesions within the upper reproductive tract. Scarring can distort or block fallopian tubes, leading to infertility. PID can destroy cilia that normally move an egg toward the uterus. Each episode of PID increases infertility risk. Damaged tubes also raise the risk of ectopic pregnancy, a potentially life-threatening emergency. If the tube ruptures, severe internal bleeding and emergency surgery may be needed. Adhesions can tether organs, causing chronic pelvic pain for months or years. This pain affects quality of life, relationships, and mental health. Managing chronic pain after PID is often complex and long-term. Awareness is our best weapon. Know what PID is, what causes it, and the damage it can do. Regular STI screening and safe sex practices prevent many cases. Ensure accessible testing and treatment for all communities. If you have pelvic pain or abnormal discharge, seek medical care promptly. Early diagnosis and treatment reduce the chance of permanent harm. Act now. Your future self may thank you. Community education, testing access, and open conversations are public health priorities. PID, an infection that can silently damage the reproductive tract, preventable with awareness and early care. If you suspect PID, seek care now. Share this information, get tested, and protect reproductive health.